know who Elizabeth is. We are also live casting this, and some may not, so I have to at least rave her up a little bit, as much as I know you dislike it. So Dr. Elizabeth Steiner Hayward is going to speak on the topic of mental health, medical, spiritual, political, and personal perspectives on a changing field. She's an Oregon State Senator who is on several Senate committees, including the Senate Committee on Healthcare. As a physician at OHSU, she teaches medical students and residents in the Department of Family Medicine. And her credentials go on and on and on, but for me, she is a friend, a dedicated congregant, someone who believes and understands in the importance of organized Jewish life to create community. And the community itself is one of our best antidotes for mental illness, by making sure that people are recognized and that people are seen, and that ideally people are directed to the care which they need. Elizabeth and her family are so dedicated to the common weal, W-E-A-L, and she lives her talk. She's a person of integrity, a person of faith, a person of intelligence, and pretty soon she's going to be a person who punches me if I go on giving more words like this. So the floor is yours, the beam is yours, the microphone is yours.
Thank you. I appreciate it. That's a very generous. Thank you. And I really appreciate all of you taking some time out of your evening to come join in what I hope will be a conversation. My plan for this evening is to talk, hopefully not at you, but talk for 45 minutes or so, maybe a little bit longer, depending on how carried away I get, which I am known to do. And then engage in a conversation more, because I'm going to be eager to hear your thoughts and your questions and your concerns, and hopefully have something of a dialogue, not just between you and me, but among yourselves together. And I want to start by saying that I come from this from multiple perspectives, many of which Rabbi Kosak has kindly mentioned. I am a family physician by profession. I've been a family physician. I've been in medicine one way or another for over 40 years now. I walked into the door of my local hospital to volunteer the day I turned 14, which was the minimum age, having decided when I was 4 that I was going to be a doctor. Yes, I'm one of those weirdos. So I've been in the medical world and seeing the impacts of mental health issues on patients since that time. And it's really been a very, very long time that I've been doing this work. And then, of course, now that I've been a state legislator for 7 years now, which is a little hard to believe, right? Yeah, I know, I see some heads shaking in the audience. I shake my head every time I think about it, too. I see this from multiple perspectives in terms of the impact on our state from our youngest Oregonians who have the adverse childhood experiences that can lead to lifelong trauma and decreased academic performance, increased interaction with the criminal justice system, and all the adverse effects that come with that, to the patients who are enrolled, the Oregonians who are enrolled in the Oregon Health Plan, and due to a lifetime of stress, have the illnesses that are related to those traumatic effects of stress and the mental health challenges that come with them. I'm also the daughter of a woman with lifelong depression, undiagnosed throughout my childhood, which led to some interesting moments. And I say that not out of disrespect for my mother. She knows that I talk about this, and she supports my talking about it, so I'm not talking behind her back or violating one of the 10 Commandments by doing so, because she thinks it's important to talk about it. And the mother of daughters who live with depression, and one of whom was a longtime volunteer for Youth Line, the Youth Crisis Line, and has gone out and talked in public high schools around the area about mental health in younger people, and is now doing the same thing in college, where she's a resident advisor for a freshman dorm and using a lot of her skills there. And then as somebody who herself has lived with depression her whole life and only diagnosed officially, when I was in my 20s, but I've seen the effects that having good medical care and a strong spiritual community can have, and I've seen what happens when you don't have those things. So I feel like, as usual in my life, I look at things in a very matrixed way, and yes, I talk with my hands a lot. So I look at things in a very matrixed way, and I think it's really important when you're talking about something as complicated as mental health, especially in the context of spirituality. I think it's really important to look at it as a multifaceted issue and not take a monocular sort of tunnel vision look at it, solely looking at the biology of mental health or solely looking at the role of prayer or meditation as we think about how do we address these challenges, or solely thinking about it from any one perspective. I really think it's important to have conversations like this where we address a complex topic from multiple perspectives. So that's my hope for this evening, is to have that conversation with you in there. And I want to start by talking a little bit about history. I think most of us know that even today there is stigma around chronic mental health issues, and many of us have lived that, either through our own personal experience or watching friends or family members struggle with mental health issues and feel reluctant to come forward and tell their stories. One of the reasons I personally tell my story so publicly, and have for a long time, is that I think I have a chiyuv, a moral obligation, to talk about it because I'm in a position of safety to do so. The only way I get fired from my job is if my constituents vote me out. So far, they've seen fit to elect me a couple of times, and all being well, 2 weeks from yesterday, they will do that again. And I don't think they're likely to kick me out of office because I talk about living with depression. But that's not true for everybody, and not everybody has that safety. And we do still live in a community, in an era when the pull yourself up by your bootstraps, and yes, I wore my boots on purpose today, that model still exists, and that mindset still exists. And I find that, to be honest, pretty problematic, and I'm guessing many of you do as well, or you wouldn't be here with us this evening. And I think that one of the things we have to talk about is how did we get there, right? Now, it was, if you think about it, the whole history of medicine is not very old. Yes, we talk about Hippocrates from thousands of years ago, but the reality is that our understanding of the biology and the anatomy of illness, physical illness, has taken a long time to come about. And until really the middle of the 20th century, there wasn't much that people could do for a lot of the physical illnesses that people suffered from, right? We didn't have antibiotics until the early 20th century, really, and they weren't in widespread use until the Second World War, right? That's really not that long ago, folks, right? We take them for granted now, and in fact, we've kind of burned through a lot of our antibiotics, unfortunately. But things like high blood pressure. Medicare, for example, was developed, I know this sounds tangential, it's not, I promise. Medicare was developed as a hospital benefit for the elderly. Why? Because really that was the only place you could do anything. We didn't have the capacity to treat a lot of chronic health issues in the outpatient setting. People would go to the hospital for surgery or for a heart attack or for something like that. Now, you can see the damage that a blocked artery causes to a heart muscle. At least you can see it, in those days on autopsy. Now we can see it with sophisticated diagnostic imaging. You can see what a ruptured appendix or an inflamed appendix looks like when you take it out. You can look in someone's eyes and see the adverse effects of high blood pressure on the blood vessels in the retina, or the adverse effects of diabetes. But it's really, really hard, even today, to look into someone's brain and figure out whether their neurotransmitters are working the way they're supposed to or not. And what's frustrating about that is that we can measure blood levels of things like insulin, which is essentially just like serotonin, which is one of the neurotransmitters we live in the brain, and we can figure out how the body is able to or not able to metabolize glucose, sugar. But we can't measure serotonin levels or norepinephrine levels in the brain. So for a long time, because we had no capacity to really understand this differently, mental illness was seen as possession by evil spirits. It was seen as moral failing, weakness of character, the pull yourself up by your bootstraps metaphor that we've talked about, the need to develop a backbone and man up and be strong. And if you have good character, you won't have depression, right? If you're doing good work in the world, you won't have depression. Well, today, fortunately, we know that that's not true. But you can understand where some of that came from, in part, for example, because people who struggle with psychosis, which basically means an inability to perceive reality the way most of us are able to perceive reality most of the days. They have hallucinations. They see things that most of us can't see. They hear things. They have auditory hallucinations. They hear things that most of us can't hear. And oftentimes, especially for people suffering from mania or severe schizophrenia, those hallucinations can manifest as religious manifestations, right? And when that happens, and especially in fairly rigid religious structures, the Catholic Church is a great example. Sometimes it's seen as great piety, but a lot of times it's seen as evil spirits telling you that you can talk to God when everybody knows you can't talk to God. Right? Only priests talk to God, or whatever. I'm exaggerating and being slightly flippant. I don't mean to be, but it's true. And in the Talmud, we know, in fact, that some of the rabbinical commentators talked about madness as punishment, and Torah talks about it as madness as punishment for not following the word of God. Some of the commentators thought that the only times that we sinned was when we were in the grip of madness or folly, and that if we were in our right minds, we can't sin. Well, we probably know now that that's not true. I'm looking at the rabbi saying, I hope that's not true. It'd be nice to have a convenient excuse. Sorry, not guilty of that sin by reason of I was in the spirit of folly. But that's not true. But it's true that those were the things that we thought about. Now, of course, we've really started to understand that a lot of mental illness comes from biochemical imbalances or other structural abnormalities of the brain, right? We know that when certain parts of the brain are damaged, people have hallucinations, either through trauma or congenital problems that occur at birth or infections, things like that. We also know that people who live with severe depression or bipolar disorder can have imbalances in serotonin or norepinephrine are two of the biggest neurotransmitters that are involved. And so we have used that information as a way to start thinking about mental illness as diabetes of the brain. And I say that because most of us know somebody. We ourselves live with diabetes. It's a very common disease, or we have a friend or family member who lives with one form of diabetes or another. I have a close colleague who talks publicly a lot about being a type 1 diabetic, Senator Linthicum from down in Klamath Falls. And he understands the analogy because he says, well, if somebody said to me, you know, Dennis, if you just prayed and pulled yourself up by your bootstraps and exercised properly and ate well, you wouldn't need insulin and you don't have to take that medicine because it's a weakness of your character that you need insulin. Well, we kind of all know that's hooey, right? And we've known that since 1914 when Frederick Banning discovered insulin and started to understand how to extract it from the pancreases of pigs and use it to treat people with diabetes, which used to be a universally fatal disease. So telling somebody with depression that if they only had strong moral character or they only pulled themselves up by their bootstraps or they only exercised enough or ate properly or prayed enough, that they wouldn't have depression is, to my mind and the mind of many people in medicine today, analogous to telling a type 1 diabetic, nah, if you behaved yourself properly, you wouldn't need insulin. So we're starting to change the paradigm, and we're talking about it a lot more publicly. Now, that is not to say that people with diabetes don't need to do any of those other things, which is a lot of negatives in one sentence. But what it means, turning it around, is people with diabetes do need to exercise regularly, and they do need to eat well, and many of them find that they're better able to manage their illness when they have a strong spiritual religious practice, right? And the same is true for a lot of aspects of mental health, and that's one of the things we're going to talk about this evening. Because all of these things, once again, are an example of the matrixed way that we have to approach any subject, any illness in medicine, right? We cannot look at, there is not a single panacea, right? I mean, yes, penicillin is a good panacea for certain bugs, but you have to take all of it, and then you still have to make sure that you're eating enough to recover, let your body recover, and you're getting enough sleep, because sleep helps our immune systems, right? So it's pretty rare that there's a disease that you can fix just with a medication. Most of the time, we do need to take a more holistic approach to it, and we know about that. But we also know that while many of these mental illnesses have a strong genetic component, and my family is a really good example of that, right? And my grandmother and my mother's sister, them too, right? And then down through the chain, we know that the genetics play a strong role. We also know that environmental factors can play a role. And some of them are the kinds of environmental factors we think about, like, I don't know about you guys, but I'm finding it a little bit harder to get out of bed every morning now than I did in August because it's dark. And last night I was driving home at 8 o'clock at night, and it really felt much, much later because it was pitch black out. And we know that people get seasonal affective disorder, right? Some people don't have depression in Oregon in the summer when we have lots and lots and lots of daylight. And then in the winter, as this time of year comes along and we start to lose our light, that triggers those chemical imbalances in their brains. And we can treat them simply with light therapy, right? Many of you may have happy lights at home. I certainly do. And they work because they trigger our brains to produce certain kinds of neurotransmitters that help us avoid that seasonal affective disorder. We also know, however, that trauma induces what are called epigenetic changes. You guys, anybody know what epigenetics are? I see some heads nodding, but I'm going to explain real quick because it's important. So I don't know how many of you remember high school biology and learning about evolution and learning that there were two competing theories back in the day about how change happened in animals. Darwin thought that change happened when there was a spontaneous mutation and an animal was born that was better adapted to its environment, and therefore it was more likely to survive and reproduce and create offspring who carried that genetic trait forward. There was a dude named Lamarck. Now, Lamarck thought that change happened because animals changed in response to their environment, and then they passed that trait on to their offspring. And the example Lamarck used was that he thought giraffes used to have shorter necks, and that when giraffes had to stretch their necks to reach food on higher branches, their necks stretched, and then they passed that on to the next generation. Well, that wasn't quite true, but it turns out actually Lamarck was more accurate than he thought, and that we were taught, or at least I was taught back in the day when I was taking biology in high school. Because what happens is when we are subjected to stresses, whether that's inadequate nutrition or interpersonal violence or environmental stress like political turmoil or war or any of those other bad things, abuse for children, it actually changes our DNA, right? And it changes our DNA not just in our somatic cells, our body cells, but in our gametes, in our sperm and our ova, right? And so those changes are, in fact, transmitted to future generations because of stresses that we undergo in our lives today, especially before we give birth. And in fact, some of my changes and my well-being were induced by how my grandmother ate and drank and smoked when she was pregnant with my mother, right? Because we know that the prenatal environment is a really, really important place for genetic development. And we know that damage can occur to gametes in utero, which is a really kind of scary thought, but also kind of a cool thought at the same time, right? So when people undergo substantial stress as children, and we talk about those in the context of this term called adverse childhood experiences, which some of you may know about, but are really important, and we're really starting to understand the impact of those. Those are things like abuse, living with domestic violence, significant food insecurity, housing instability, things that we can think about that would traumatize young children, right? We know that those things have lifelong ramifications for people's physical and mental health because they change their DNA, which is fascinating to me, right? And really cool because it means that if we can prevent some of those things, we can have significant impact down the road, right? And there are studies that show this kind of stuff. It's pretty cool. So those triggers, having the genetics alone certainly makes it more likely that you're going to get depression or anxiety or schizophrenia or bipolar disorder. But you probably also need a range of other triggers. It's probably a multifactorial problem. And again, we're still teasing out a lot of this day by day. So, and we see this, we know from some studies, for example, that people with severe PTSD, particularly from childhood trauma, have babies that are lower birth weight because the cortisol levels are higher in the parent throughout the pregnancy, in the mother throughout the pregnancy. They have babies who are jitterier and don't sleep as well because of their genetic changes. It's really fascinating, right, about how this happens. So how do we think about treating, based on the biomedical model of mental illness, how do we think about addressing that? Well, clearly, now that we understand more about the role of neurotransmitters and some of the structural abnormalities, we can develop drugs that target those. I'm talking about depression a lot because that's the one we probably understand the best in terms of the exact neurotransmitters that are involved. But everybody in the world knows about Prozac at this point. Prozac is what's called a selective serotonin reuptake inhibitor. What does that mean? It means that some people with depression don't have enough of the neurotransmitter serotonin in their brains, and that affects how they think about stuff. It affects their overall mood. And when that neurotransmitter is released from one nerve to the next, if there's not enough of it, then there's an ongoing lack in the brain. But if you use an SSRI, a selective serotonin reuptake inhibitor, then that keeps it circulating in the space in between the neurons longer. It's kind of cool, right? I think it's kind of cool. And there are similar drugs for treating norepinephrine deficiency and things like that. There are also drugs that we know work, but we don't know why, right? Some of the traditional antipsychotics, haloperidol, things like that, that help people with schizophrenia and other forms of psychosis, we're not exactly sure why they work. And that's true of a lot of medicine. We know drugs work and we don't know why, which is also kind of weird in my mind, but true. So we have that ability to treat stuff. So medication is absolutely really important for a lot of forms of persistent mental illness, right? Some people need to be on them for the rest of their lives. Some people can take them for a shorter period of time and then after doing other things to help address the underlying causes of the depression, the triggers, can go off of medications. There's not a right or wrong. The analogy there is type 2 diabetes, right? Type 1 diabetes means your pancreas isn't making insulin at all, right? It's not making the hormone that you need. And that's a lifelong condition and there's nothing you can do about it and you just have to supplement with insulin. Type 2 diabetes has to do with insulin resistance, right? The cells become less capable of using insulin to take sugar in and use it properly in the cells. And sometimes that comes from physical inactivity, poor diet, overeating. Not always. I know plenty of really thin, active people who eat really well who have type 2 diabetes. But sometimes that's true. And so sometimes, just like with depression, we can start treating someone with a medication that helps them use their insulin better, helps them get the sugar into the cells and not in the bloodstream, and then encourage them to make lifestyle changes like increasing their exercise level and eating better and things like that, and eventually get them off of the medication. So there's analogies with both kinds of diabetes for this. But medication alone is often not enough, and sometimes it's also not necessary. We know that cognitive therapy, talk therapy, can be incredibly powerful for people with mental illness. And in particular, things like cognitive behavioral therapy or dialectic behavioral therapy, which teach people to reframe how they're thinking about things. And I could spend a long time talking about CBT and DBT, but it's not my true area of expertise, and I'd encourage you to read about it if you're interested. And there are other people. Actually, Joanne, where are you? Hiding? She left. Okay, Joanne actually has run some DBT programs here and is trained in it, and so she's a great person to talk to if you're interested in learning more about it. But she's trained to work with people and teach them how to use DBT in their lives, which is pretty darn cool to have someone with that expertise as part of our team here at Neveh Shalom. So cognitive therapy can be really important. We know that exercise helps. Why does exercise help? Well, it boosts endorphins, it decreases pain. Pain and depression go hand in hand, and it can mess with your sleep, and poor sleep can increase your risk for depression, and it becomes this nasty, vicious circle, right? And you become, if you don't get enough sleep and you're depressed, you're more sensitive to the pain. So exercise done properly can boost your endorphins in your brain, can reduce pain, can help you sleep better, all of which will help alleviate depression and anxiety, right? Good diet can help. Some people are very sensitive to certain food triggers, and we don't know exactly why, but we do know that it's true. And so learning about one's own body and figuring out what food triggers do or don't work. And then there are things like meditation, and this is where we start to make the transition into talking about the spirituality aspect of this, which I think is really important. And I'm just going to put this on here so I can at least keep some general sense of the time and make sure I'm not running over and stuff. So meditation clearly changes brain function, right? And we don't exactly know how. It's, again, we know it happens and we can measure it because we can do electroencephalograms on, EEGs, where we stick a bunch of electrodes on people's heads and measure brain electrical activity while people who have a lot of experience meditate, right? They've done this a lot with Buddhist monks who meditate a lot as part of their religious practice. And we know that it changes brainwave form, and it amplifies kinds of brain waves that help reduce the sympathetic nervous response, which is our fight or flight, high stress level response, and increase parasympathetic response. Parasympathetic tone is the tend and befriend, right, as opposed to fight and flight. That's the one where we're nurturing other people, we're tending to our own well-being, we're feeling calmer and more relaxed. And so parasympathetic is good. Sympathetic nervous system is important, but ours tend to be activated much too much in this world that we live in now. And so it's really important to use things like that. The interesting thing about meditation is there are lots of different ways to do it, right? And many of you, I think, have experience with meditation. And it's a long-standing practice that has strong overlaps in many, many religious and spiritual traditions. How many of you have ever walked a labyrinth? Right? Lots of us. And walking a labyrinth is a form of meditation. It's a form of really focusing in and using that physical activity of putting one foot after another. I know I'm not supposed to walk away from the mic, even though I tend to walk and talk. Putting one foot after another in a very deliberate, organized way is a form of moving meditation, right? Some people find running because of the rhythmic activity. The thing about meditation for most people, it's about the mindfulness of focusing on one thing at a time, right? And doing it in a sort of rhythmic, repetitive way. And there isn't really a right way to meditate. There's a very interesting book out right now that I'm not going to get the title quite right of, but it's something like Meditation for Fidgety People. Me. Because there are a lot of us who have a lot of trouble settling our minds down enough. But like anything else, it's something we get better at with practice. And the thing is that meditation, prayer is meditation, right? And meditation is often prayer. A lot of people, in Judaism, a lot of people use Shema as a word that they say over and over and over again for their meditative practice. And it's a word that has very deep meaning to Jewish people because it's the central tenet It's part of the central tenet of our faith. So finding something that connects you in that way connects your spiritual and your meditative practice, your religious and your meditative practice in together. And we know that those changes in the brain that are brought about by regular meditation, whether it's through moving meditation through a labyrinth or reciting a mantra like Shema or deeply focused prayer of one form or another, changes our brain waves in ways that increase the kinds of neurotransmitters we want and decreases other ones. It also decreases cortisol levels. Cortisol is the hormone that boosts our sympathetic nervous system and decreases our immune system function, which also makes us more prone to the kinds of things that can trigger poor sleep, pain, and the inability to work with the other modalities to address mental health issues, right? So I've been doing pretty good remembering things, but I do have to check my notes occasionally. And they've done a lot of studies on this stuff now, right? It's really interesting. If you just Google search mental health and spirituality, Google Scholar will come up with 250 articles like that. And if you do what I, as an academic family physician, am prone to do, which is to go down rabbit holes in the medical literature, you open up one of those articles and you look at it, and then you take the references and you start looking at those articles, and then you take the references from those articles, and pretty soon you've got 1,000 or 2,000 articles that all address this, especially because some of those articles that you started with were review articles where they look at a lot of different articles. So you have an opportunity. And why do people do that? Why do people talk about it? Because people understand, and the medical world now understands better than it ever has, how important religious and spiritual practice are in people's lives, and how traditional allopathic Western medicine doesn't have all the answers. Right? And yes, it's great that we now have medications that will treat a lot of these mental health issues, and those are necessary, but they're not sufficient. And so understanding the dyadic nature of working in the religious and spiritual world and supporting patients and people living with mental health issues in that regard of their lives, while also offering the medical treatment, can be incredibly important. And it's very person-centered care, right? One of the things as a family physician that I pay a lot of attention to is, am I treating people like a disease, or am I treating them like whole people? Now, I hope that most of the time I'm treating them like whole people. And that means that I'm inquiring after, what is their social life like, right? Not like, how many friends do you have, dear? But do you have a network of people around you who support you, right? We know that having close personal relationships boosts the production of oxytocin, which is the hormone that's released in mothers' brains when they nurse their babies, right? And it helps with bonding. So I have a close friend, a woman I grew up with. We've known each other basically since she was born, since I'm a little older than her. And she's a professor in the School of Nursing at Johns Hopkins. And a lot of her research has been around helping elderly people, especially poorer elderly people, age in place and have the social supports and the physical supports that they need, that they can maintain their independence and stay in their homes. And she's actually done studies. Some of her earliest work was around the role of close personal relationships in increasing immune function by boosting oxytocin levels through through helping facilitate those personal friendships. Many of which, in that community in Baltimore, came through the church, right? And that spiritual community was a really important part of people's social support network. And the people who had that tended to be, on balance, less at risk for dementia, less at risk for some of the chronic illnesses that tend to afflict people as we get older, less at risk for depression and anxiety, because the brain hormones have been boosted in the right way. So it's really fascinating stuff. And there's been a lot of research on it. Now, occasionally, we do see sometimes when Strict religious adherence can actually be a manifestation of mental illness. The most classic example of this is obsessive compulsive disorder, right? You see somebody who is really, really, really particular about adherence to, in our tradition, kashrut or Shabbat, and they're very, very, very precise. And they may be reluctant to break those rules even when it's religiously permitted. They may be reluctant to take somebody to the hospital, you know, a woman to the hospital if she's having a baby in labor on Shabbat, right? Because they don't want to drive, even though we all know that that's absolutely appropriate. And the concept of pikuach nefesh far outweighs, saving of someone's life, far outweighs the issue of Shabbat, right? But people whose mental illness has manifested itself as really rigid observance have trouble making those changes, whereas the vast majority of religious people don't have any trouble doing that because they understand that there's a prioritization of observance. So we do see that sometimes that can be a problem. Some of the interesting literature that's happening now that I find surprising, to be honest, is that people, so let me just take one step back. I realize there's one thing I haven't done. We tend to use the terms religion and spirituality sometimes in an overlapping way, but I do think it's important to understand that there's a distinction, right? Spirituality is having a sense that there's a higher being, God, an overwhelming spirit that's something more than human and something larger and more difficult for us to understand, and that has a positive, sometimes negative, but overall positive impact on the world, right? Religion, I'm simplifying a little bit, I freely admit. Religion is taking that sense of spirituality and structuring it, right? And putting it into an organized format that has rules, right? Mitzvot in our case, rules and ways of approaching our spirituality. It doesn't mean that we can't take alternate forms, right? Whether that's different branches of Judaism in our case, or people expressing that. You know, our Shomrei Teva group expresses their connection to spirituality and religion by doing things that help protect our planet, right? Our Tikkun Olam group, the groups that help with making meals for outside in, or helping people in our community who are in need because of a bereavement or an illness, they do it through social justice and community connection. And so they use that structure. Religion in general, religious connection with a religious community, is generally considered to be positive for people's mental health. Why? Because there's a sense of structure and order in your life. There's a sense of strong community. There's a sense that you have a group of people you can turn to when you're in crisis. I think most of us would feel that pretty much anybody in our kahila, even if we don't know them really well, simply by the virtue of the fact that we're all members of Neveh Shalom, I could turn to almost anybody and say, could you give me a hand? I'm really struggling right now. And people would say yes, right? So having that built-in community can be really important. Having clergy that we can connect with and trust is a really important part of that, and that's something that religion provides for us. Occasionally, religion can be detrimental to one's mental health, and we see this sometimes when there's, I'm totally blanking on the word, but basically there's a incongruity with how one perceives oneself and what the religious tenets are. We see this a lot in more fundamentalist Christian faiths that oppose homosexuality, and kids who are brought up in that tradition, in that faith tradition, identify as homosexual, right? And there's this huge asynchrony, and they feel guilty and miserable and have depression and anxiety that can be overwhelming for people. So that's a really important time to be aware that there's this cognitive dissonance between the teachings of the faith and the self-perception that can lead to religion being a problem. But the vast majority of the time, being part of structural religion helps with people's mental and physical health. Turns out that if people think that they have an obligation to a higher power, they're more likely to take care of themselves physically, It's kind of interesting, right? Because people tend to see themselves, their bodies are not their own at some level. They are a gift from God. And so that's a reason for people to take care of themselves. And we think that having this strong community boosts immune function, and it improves other kinds of changes in our bodies. Spirituality is a little bit more tricky. And that's why one of the challenges that I faced in preparing for this evening is trying to understand how to think about spirituality as opposed to religion. Because it turns out that when you're a spiritual but not religious person, sometimes some of the literature suggests that it can actually increase anxiety and depression. Because there's not a really clear-cut way to manifest your belief structure, right? Or to approach your belief structure. And that creates anxiety for people. But it's interesting. But that spirituality can conversely come into playing a very important role for recovery from addiction, for example. I think most of us know that 12-step programs rely heavily on acknowledgement of a higher power, no specific version of a higher power, but a higher power, and using that acknowledgement and that willingness to surrender your own challenges and place them in the hands of the higher power and use that strength can be very powerful for some people. And that's a situation where, in essence, the 12-step program becomes the religion, right? Which is something sometimes people see as a benefit and some people criticize. But I'm not judging that. I'm just showing an example of how spirituality without what we might consider an organized religion can in fact be very helpful to people's mental health. The other thing that I have found really interesting in thinking about this research is the role of being outdoors in nature, right? Now, I don't know about the rest of you, but one of the reasons I live in the Pacific Northwest is because I like being outdoors, right? Last Thursday, I had part of a day off, and my husband and I went and took a 3 or 4 mile hike in Forest Park, and you come home and you just feel a little more chill. And over the weekend, we spent some time putting our garden to bed for the winter and just being outdoors and getting our hands dirty and being in the sunshine and listening to the birds helps calm you down. There are even studies that talk about nature bathing, which basically just means going out in the forest and walking around a bunch. It doesn't mean getting naked in the leaves, although you can if you want. But nature bathing, again, ramps down our sympathetic nervous system, ramps up our parasympathetic nervous system, which we want to do. Standing barefoot on the ground, not on the sidewalk, but on the ground, for 10 or 15 minutes, can do the same thing too. You don't even have to go anywhere. You can just stand on a patch of grass for 10 or 15 minutes. And that connection, that grounding, probably triggers some of the same things that meditation and deep prayer can trigger. So I think I'm getting toward the end of the full hour, but I want to talk about a couple of things about why this matters to me personally, given all those roles I talked about at the beginning of our conversation here. And I want to talk for just a minute about something that's not in the title of my talk, which is economics, right? I have data here that show things that I know. For example, people with severe persistent mental illness, bipolar disorder, schizophrenia, their lifespan is on average 25 years shorter than the rest of us, right? If it's not well treated. Why? Because they have, the rest of their health conditions are not well treated. It is really hard to engage in your own, to be a partner in your own well-being, in your own care, if you're living with untreated depression, or if your worldview has nothing to do with the reality that most of us live in every time. And you've got voices telling you, no, you don't need to take that medication the doctor said you need to take for your diabetes because it's poison. And you don't want to do that. That doctor's trying to poison you, right? Pretty common delusion. And so it makes it very hard to help people live productive lives. They also tend to be more at risk for tobacco addiction, alcohol addiction, substance use disorders of a range of kinds, which again shorten their lifespans. I find that as a person of deep faith who values every person's life a lot, and as a policymaker who believes strongly in human potential to be very problematic. I think we're failing people in our society, so it's one of the reasons that I care about this so deeply. But there's a real economic cost. Estimate in 2017, from 2016 data, but an article was published in 2017, in the United States, emergency department use related solely to mental health issues, $38.5 billion with a B. All of these numbers are in billions. Incarceration, because we know that a significant percentage of people who end up involved with the criminal justice system do so because of mental health or substance use disorder problems, $37 billion. Medical comorbidities, the untreated diabetes, the untreated high blood pressure, the heart disease and lung cancer that comes from tobacco use, somewhere between $135 and $350 billion every year. And lost productivity in the workplace because of subacute problems or untreated depression, but people keep functioning, they keep going to work, almost $200 billion nationwide. Now, I don't know about you, but when I add all that up, it gets me to somewhere between $400 and $600 billion a year in this country. And frankly, I can think of a lot better things to do with that money. So from a fiduciary, I mean, one of the things that Rabbi Kozak didn't mention that I do a lot is I'm a budget person, right? I'm the Senate chair of the Health and Human Services Budget Committee. And I do budget a lot because I think that your and my tax dollars should be well spent, right? And I think about that because I feel like I have a fiduciary responsibility, right? A trust responsibility to make sure that I'm taking care of the state in the way that it should. And that certainly comes from my position as a Jewish person of deep faith, right? I mean, the whole concept of tikkun olam can extend to making sure that every Oregonian gets the services he or she needs to be a healthy, productive member of society, right? And if we don't spend our dollars wisely, we can't do it. Well, every dollar that we spend treating a preventable problem is a dollar we can't spend in our education system, right? It's a dollar we can't spend in making childcare more affordable and higher quality for parents who need to go back to work when their kids are little, or want to go back to work when their kids are little. Both are reasonable. And making sure that those kids have early childhoods that do not include trauma like food insecurity or housing instability, which is very traumatic for kids and doesn't interfere with their education, and where if they have mental health problems, they get diagnosed early and treated appropriately so that they can succeed in their education, right? So I feel really strongly that with all of my different perspectives from this entire matrix, that we have to take a multifaceted approach to dealing with these programs and with these issues and move upstream as much as possible. So that's a lot of the work that I do there. And again, to me, that's a very Jewish way of looking at the world, right? So for me, part of being a healthy, whole person is not only taking my medication every morning to treat my depression, but knowing that I'm going to walk through my day with a sense of structure and order that's provided by my approach to religion and faith. And for many people living with mental illness on a day-to-day basis, that's part of what is their treatment. So that's, to my mind, how we bring it all together. So I'm going to stop there because I think that will leave us enough time to have some conversation. And I hope that some of you might have questions or comments that we can talk about together. Oh, there's another microphone and everything. We're so fancy.
Indeed. So, any questions, comments?
We've got a microphone, which is good because we're being live streamed, so we want people to be, and it's being recorded, so we want people to be able to hear.
Yeah, my name is Margaret. I was wondering about Oregon being such a poor state. I think, isn't it 1 out of 5 children below the poverty line?
So unfortunately, Oregon isn't that uncommon. It's probably a little worse than some states, better than others. But one of the problems that we face in this state is that although the economic recovery has been strong, as is true in most of the nation, wages have not risen at the rate that we would expect in an economic recovery. So by this point, we would expect to be back to a place where that number had dropped down a lot. And it hasn't, because parental wages haven't gone up. Now, one of the things that's going well, as an aside, is that our teen pregnancy rate's dropping a lot. And we know that when women become mothers when they're in their teens, that the risk for poverty, lifelong poverty, for them and their children is much higher. So we're doing a good job of addressing some of the causes of teen pregnancy, which will ultimately help turn that around. But our housing rate, our housing challenges have not helped us, right? We have an inadequate housing supply, and so housing costs have gone up, and that pushes people into poverty in other ways, or it leads to the effects of poverty because people have less disposable income. And that contributes to the stresses that we were talking about earlier, these adverse childhood experiences that predispose kids to have mental health challenges down the road.
I'm Michelle, and I see the whole mental health issue, especially for children and teenagers, as quite a challenge in our state, in the sense that parents and teachers often recognize that their child is having a problem, but then even in the Portland metro area, when they go to seek help, there aren't enough psychiatrists and psychologists who treat youth mental illnesses. And these children and these parents end up time and time again in the emergency room because their children are in crisis, only then to be given a list of numbers that are approved by whatever Oregon Health Plan or by their private insurance. Try calling these hundreds of psychiatrists in the area only to find out that the ones who do see children, they're full. They're not taking any new patients. And I'm wondering, what is our government doing, or what other resources are available? I'm sure I'm not the only one. Luckily, my child hasn't needed help beyond what my insurance can give him. However, there may be somebody here like me who's run into 2 or 3 people who are struggling to get help for their children. Do you have any insights as to how?
Yeah, this is a huge problem, and it's unfortunately not the first nor the last time I'm going to hear about it. And we are doing things. I actually helped pass legislation in 2017 that created a new large fund to help set up more training programs for mental health professionals in the state, psychologists, social workers, licensed professional counselors, specifically targeting areas of need, both in rural and urban areas. Now, that's a pipeline problem, right? So it's going to take us a little while to do it, to get there. But we also know that when we train people in a certain area, they tend to be more likely to stay in practice in that area. So if we train Oregonians in this area, then we have a chance that they're going to stay in practice here. We also know that we need to have better payment for mental health professionals. Oregon has mental health parity laws where we're supposed to pay for mental health care the way we pay for physical health. It's not happening. And in 2017, we also passed legislation that asked the Department of Consumer and Business Services to do a study to evaluate this better, and then to basically work with our insurance companies to ensure that they are paying mental health professionals better. When we do that, we'll be better able to attract providers in from other states and help address some of the workforce shortage. There are other things that we can do that don't actually require trained mental health professionals, though, for some kids. For example, in the Gladstone School District, the superintendent there, a guy named Bob Stewart, who's wicked smart and thoughtful, has done a lot of work training the teachers in trauma-informed practices. And when you do that, you can actually help de-escalate some of the trauma and help kids stay in the classroom. The analogy I use a lot is sprained ankles. Many of us have had a sprained ankle at one point or another in our life. And when you have a kid who sprains their ankle, it's really important to rehab it properly, right? Because if you don't, then that ankle is always weak, and every time you sprain it, it's just going to keep getting worse and worse. The same is true for mental health challenges. If we intervene early, and treat it in ways that help strengthen the child or the young adult who's struggling with them, then that decreases their risk in the future, and it also gives them tools to cope when they do start to struggle again, resources. So when we have more school counselors and teachers who are trained in trauma-informed practices, and we have that opportunity to surround the child in, I wouldn't call it a therapeutic environment because that's an overstatement, but an environment that's more supportive, where they're going to be treated, where they're going to be responded to appropriately, we have an opportunity to augment the work that's being done by our mental health professionals. It's not an instant solution. None of these problems, unfortunately, have instant solutions, but it's something that the government recognizes and is taking a lot of steps to try to address.
Thank you, Elizabeth. What you said was important and true. And so I'll come out as somebody who has taken Prozac for about 30 years, and I'm very lucky that it's worked for me. Mm-hmm. I worry about my granddaughter who's had a recent crisis, mm-hmm. and I wondered if you know or what you think about the DNA testing for appropriate medication.
I'm sighing, Joni, not because I'm upset about the question, but because it's a complicated answer. So what, DNA. Oh, DNA. Yeah, it's hard to hear. No, so what Joni's referring to is that one of the problems with treating depression is that it's sometimes a sort of shotgun approach with medications, right? You start someone on a first-line medication and you have to wait 2, 4, 6 weeks to see if it's working, and if it's not, you have to try something different, and you start the process all over again. And it's frustrating to people. And sometimes you really can't find a medication that works for somebody, and you have to go to something that's really unusual. There are some DNA tests now that can identify genes that make it more likely that people will respond to one class of drugs over another class of drugs, or will metabolize drugs in a different way, and therefore you need to use one of these atypical drugs. For some people, for people who don't respond easily to treatment, I think they're probably a useful tool in the hands of the right provider. I personally would not feel competent to order that test and interpret the results and use them appropriately. You have to work with somebody, a health professional, who has experience working with those tests and understanding the implications of the results, right? And there aren't lots of people around who do that yet. I think the day is coming when we'll be doing that a lot more, not just for mental health issues, but for high blood pressure and diabetes and pretty much any other disease where there are a range of medication choices. But right now, the return on investment for those tests for most people to do it widely is probably not great. It's probably better to take some of the traditional approaches for a while, even though it's frustrating sometimes, and reserve those tests for the people whose conditions don't respond to that traditional therapeutic step method. That will probably change in the not too distant future.
I don't like my.
Hi, Jen.
Is it off? On?
Yes, it's on.
Oh, Elizabeth, thank you. My question is, it's one of those that starts with, I have a friend. She's Jewish, that's just coincidental. My question ultimately is, she knows that she suffers from depression. She's a peer of mine, and she sees, I don't know if it's DBT or CBT, but I am pretty certain she's not on medication. Mm-hmm. My question is, she engages very frequently in behavior that's like the pushing the friends away behavior. And what I don't know, as one of her closest friends for the past 30 years, does that actually mean, like when you talked about schizophrenia and people will hear voices and they're outside of other folks' reality, does that actually mean that she would like, I don't know if attention is the right word, reaching out, or if it does actually mean that being pushed away, that it's appropriate to remain distant?
I wish I could give you a good answer to that, but the answer is I can't. And I'll tell you why. Because there are a lot of reasons why someone like your friend might push people away. Off the top of my head, it could be guilt or a sense of poor self-worth, right? Lack of self-worth, and saying, I don't deserve to have friends. And that can stem from the depression and the anxiety and the feelings like, I'm not a good person, I'm not doing good things in the world, so I'm going to push my friends away because I don't want them to be tainted by me, right? And that's the language we hear a lot. It could be because she not only has depression, but she may have some form of a personality disorder, which can make it challenging to have friendships for some people. Those can stem from a whole range of reasons, and they're very tough to treat. It may stem, I wouldn't want to claim it, but from some smaller version of irrational thinking, right? I wouldn't necessarily call it psychosis per se, but there may be some small voice in her head that's saying to her, that person isn't good for you, when they're in the when she's in her worst place. So the range of reasons is large, and it makes it tough to give you a good answer to that. I wish I could help more, and I know how difficult that must be to want to do the right thing for your friend and be really unsure what that is. And it's a challenge that I think, I'm glad you asked the question, because it is a challenge that a lot of people face in dealing with family members or friends who have struggled for long periods of time with mental health challenges, because they don't always behave in rational ways. And that makes it really tough. And sometimes they'll tell you they want one thing, and sometimes they'll tell you they want something else altogether. So I can't give a great answer, but I get what you're saying, and I know how hard that is. Sure.
So first off, thank you for coming. My question is, when critiquing the pull yourself up from your bootstraps mentality, I think it's easy to throw the baby out with the bathwater in the name of compassion. I contend that it's unhelpful and uncompassionate to tell people that they are not responsible for making good decisions, because that can lead to people not improving their behavior and not taking steps to help themselves even when they are capable of doing so. So in your view, what is the best way to avoid this stifling aspect of the metaphor, pull yourselves up by the bootstraps, but to inculcate the positive values it advocates of taking responsibility for your situation and making good decisions so as to improve your life?
Thanks, Lev. That's a great question. And you're right. You can't absolutely go too far along this. What I would say is this. It depends a lot on where they are on the spectrum of, let's just use depression, right? If you have somebody who has mild depression, then you can engage with them in a conversation about the things that they need to do to be an active partner in their own well-being, right? And I've always firmly believed that we want to help people be active partners in their own health plan, right? And whether that's diabetes, and that means taking your medication and measuring your blood sugars and eating right and getting some exercise and trying to sleep enough and all those good things, which are about personal responsibility, but more accurately, more importantly, I think, even than personal responsibility, having a sense of your own self-worth and your own agency, right? Your own ability, your own capacity to be a partner in your own well-being. Now, on the other hand, when you've got someone with really severe depression who can barely get out of bed in the morning, that's a time when you just throw all the self-responsibility, the personal responsibility part out the window, because there is just no way to do anything other than set someone up for failure. When you say to them, look, you've got to be an active partner in your own health care. You're lucky if you can get them to take their medication every day, right? So we have to figure out where on the spectrum people are at any given time. And health professionals have the tough job sometimes of assessing where people are in their capacity to do that and encouraging them to believe in their own capacity and to help grow that capacity, but also not setting unrealistic expectations that will make people feel like they're failing and therefore to fail to comply with other parts of their treatment. Does that make sense? Does that answer your question? Okay, cool. I think Lori behind you.
Thanks for being here. If you think about the Jewish people as a whole and how we have had to run from country to country and a lot of persecution, and we are lucky to live in this particular time frame in this country where we've been pretty much safe from all of that. but over time, over thousands of years, how has that fight or flight affected us as a people?
It's a really good question, and some of the reading I did preparing for this talk actually talked about that a little bit. I don't think we can know, per se, exactly how it does. We certainly know that children born to Holocaust survivors, especially ones who were in the camps and had very poor diets, the women in particular, those kids had more health problems because of the epigenetic changes that we talked about earlier. The ongoing low-grade persecution is a little harder to measure the effects of it. I think it certainly does make us a little bit more edgy and anxious sometimes. I am not the only Jewish person I know who carries her passport with her all the time. Not kidding. It's in my handbag. And some people laugh and say that's a little bit nutty, and some people say, yeah, that's a sensible precaution. So I think that effect is real, especially those of us who have a lot of public interaction and see the day-to-day anti-Semitism that can come up in sort of low-grade microaggression sort of ways. And those absolutely do have an impact on our ongoing well-being. How much I can say that my physical well-being relates to the pogroms that my great-great-grandparents suffered through, I don't know that I can answer that question.
What did you say you carry with you all the time? Passport.
My passport.
Oh, your passport.
Mm-hmm. Yeah.
Hi, I'm Corinne, and I first want to say thank you for being here. I think it's a really important discussion we're having tonight. So in recent months, we've been following the local news, and places such as Unity Behavioral Health have had problems. I just heard that LifeWorks in downtown Portland is shutting down, and I'm real concerned about, for those people who really do want to access the services that should be available to them, I'm really concerned about the reduction in the number of places people can go. Is that a financial issue? Can you give us any suggestions on that?
Part of it's workforce, the same answer that I gave to Michelle's question. So workforce is always a challenge. Hiring and retaining skilled mental health professionals is hard. Some part of it's financial, the pay parity issues that we discussed earlier. Is an issue. I don't really understand what happened at Unity. It had enormous promise, and I'm very dismayed by that. I mean, I was aware of the plans for it long before I think most people were, because it's a conversation they were having with legislators pretty early on. And I went on tours of it, and I talked with the leadership of it, and I don't understand what happened there or what the plan is for the future. But we've got to do more to create spaces like that that are not hospital emergency departments, because hospital emergency departments are really crummy places for people in mental health crisis. There are a lot of things in my life that I would like to wave a magic wand about. This is one of them. Having a good workforce that's well paid, and that means that everybody has access to affordable, high-quality mental health care. I don't have that magic wand, but I do have a lot of colleagues and I who are committed to continuing to work on it and try to find ways to address it. But I don't have an instant answer.
Going back about 60 years, in an era when things were much less sophisticated in terms of psychology and mental health, I was in a psychology course in college, and they basically said that people who face mental health issues, a third of them cured themselves, a third of them were cured by the help that was available, and a third, nothing cured. So part of what I'm asking in terms of the economics and the challenges we have as a society to provide the help for these people is, where are we on that spectrum in terms of what we now have, in terms of its effectiveness, and in a governmental reference, cost effectiveness to really deal with it, because part of our tendency is this, there is something that will help everybody, but how real, I'll use the term realistic gently.
It's a great question, Steve. I don't know where we are in that third at this point. I don't know that I ever heard that statistic. I'm not doubting it. I'm just saying I don't remember ever being taught it. And I don't know where we are with that now. I think it also depends a little bit on how you define curing yourself, right? If curing yourself means being taught the principles of CBT and then being able to use them, is that curing yourself? Maybe. Is it curing yourself if you decide what I basically need to do is go running every day and that's what's going to keep me from getting depressed? That may count as curing yourself. I'm not sure it's much different from being taught CBT, because you also have to be able to learn how to keep yourself injury-free when you run, right? We have a lot more medication options for people with severe persistent mental illness now than we had 60 years ago. And we are learning more about how to decide, analogous to Joni's question, we're learning more about how to decide which drugs work better for which people. But we also have some weird societal barriers to treatment. One of the problems is, if you think about housing, right? A lot of the people in Oregon and nationwide who are houseless because of severe persistent mental illness. Well, we need to put them in support, they need to be in supported housing. But a lot of times, they can't get into that supportive housing unless their mental health issues are stabilized and they've been taking their medications. But it's almost impossible to take your medication consistently if you're houseless, because it's hard to keep track of where your medication is, and it's hard to know what the time of day is. And so it's really hard to be an active partner in your own health if you're basically worried about whether you're going to make it through the night, right? So there are things that we need to take into consideration that are active treatment and that will allow people to engage, as Lev quite rightly pointed out, in their own treatment, that we need to do a better job of facilitating. And that ultimately, I mean, it's really expensive when the police, I've just spent 5 days out in Eastern Oregon during Roundup. That's where I was between Rosh Hashanah and Yom Kippur. It was sort of an interesting time to be out there. But I was out at Pendleton Roundup. And I spent a lot of, I was out hanging out with my colleague Bill Hansel, who's the state senator from out there. And Bill and I like to joke that you couldn't get much more different than the two of us, you know. He's a Baptist, I'm a Jew, and he's man and I'm a woman, and he's a Republican and I'm a Democrat. And I'm from the East Coast and he's from Athena, Oregon, and, you know. But we get along very, very well, in part, I think, because our faith brings us together. We have a different approach, but we're both people of pretty deep faith. He came and celebrated Purim last year with me in Salem. It was kind of fun. But one of the things we did while we were out there was we spent a lot of time talking to law enforcement about the intersection between behavioral health and law enforcement. And that's something I'm doing a lot of work on right now, because more often than not, people with mental health issues, whether that's due to endogenous mental health or mental health issues induced by substance use disorders, or sometimes dual diagnosis, right, to both of them at the same time, end up engaged with the criminal justice system primarily because of property crimes or public nuisance kinds of things. But jails are not good places for people in mental health crisis, just like emergency departments are not. So part of the conversations we have to have is how do we divert people into the right kinds of care? And jails are expensive. And ERs are expensive. And so we're going to have to spend money to take care of people, but we don't have to spend $400 to $600 billion a year to do it necessarily. I don't know if that really answers your question, but I tried.
We're going to have, I think, just time for one more question.
Okay, not to be so happy about showing my age, but back in the Kennedy and Johnson administrations, coming out of Boston area, we had really good community mental health centers, even before they closed down the mental hospitals.
Just hold the microphone really close to your mouth. There you go. Perfect.
We used to have very, very good community mental health centers in throughout Massachusetts, actually, but certainly in the Boston area that I can remember under the Johnson and Kennedy administrations. And I believe when I left the country in '77, that all of these things were closed down by the Reagan administration, who decided we didn't need mental hospitals anymore, but didn't bother to keep up the clinics either. So what's the possibility of simply pulling out some of these old blueprints, which were actually economically viable and effectively treated people and helped them return to the community and did the work that they were supposed to be doing? Is there any movement at all? Does anybody look at the old blueprints?
I don't know the answer. It's a great question, and it's a part of history that I was not as aware of, and I appreciate your educating me about it. So I don't know, and I'll talk to some people who know more than me, because I think we always need to look at good ideas, whether they're new ideas or new old ideas, or old new ideas. I don't know which direction I'm supposed to say that. But I do think that there are always things that we can learn from what's worked in the past, and it's good to know about that, and I know people I can talk to, so I appreciate you bringing it to my attention. Thank you so much for inviting me to come talk with you. My pleasure.
See, the thing that's great about Elizabeth is I always know she's going to over-prepare, by which I mean take it seriously, the mandate, the task, and do her best to educate us. And I want to thank you for sharing both your commitments on the political level, your own family history, and the way that mental illness touches so many of us, and of your real effort to show how faith and faith communities are also one small part of a multifaceted, matrixed approach to mental health and caring for the least, the lost among us. I want to remind people that this is an ongoing educational opportunity we have this year with our at the intersections of science and spirituality. And coming up in December, we have our scholars in residence. We're bringing in from Israel Dr. Ronen Meir and Dr. Debbie Meir. And Friday evening, December 7th, Ronen Meir will be speaking about Moments of Discovery, a personal journey through science. He is a world-renowned scientist with the area or specialty of science education. His wife is an environmental scientist, and on Saturday afternoon, December 8th, she'll be speaking about environmental health in our home, school, and community. How much is in our hands? And then on Saturday evening, December 8th, Ronen will return and speak about how scientific thinking leads to prosperity and opportunity, the lessons of Israel's startup society. So we've got very excited that we bring them in for our third annual Scholar in Residence Weekend. And of course, this is in memory of Yoni Shur, who was killed in a terrorist attack in Istanbul. And we and the Shur family, who helps underwrite this program, do it both to keep his memory at the forefront and to use it as an opportunity so that we as a community continue to be adult learners and to enrich and expand our own horizons, because we Jews are people of the books, and we know that we have to keep learning, growing, engaging, and that here at Neveh Shalom, we also have the faith that by doing that, we develop the deepest, most enriched faith, one that is capable of standing up to any sort of scrutiny, an adult faith that is open to the best that our scientific minds and our spiritual hearts can teach us so we can be better human beings. Thank you all for coming out tonight. It's been a pleasure.